Hi, I just wanted to discuss a few of my thoughts on the video you released on office hysteroscopy. I just wanted to say first that I'm glad, actually, when I look at it, some of the procedures you use are certainly a lot less worrying than what I first thought. However, there are a few concerns, is that I'm glad you're not actually talking about office hysteroscopy, you're talking in clinic hysteroscopy, because in the UK they do office hysteroscopy, and the issue with that is that the wound perforations are a lot more common than statistically noted, and they are often not facilities to, if a perforations happen, to take them to one side or put them on a bed and monitor them in another room. Quite often they will have to leave the clinic, walk all the way around to the other door and go in the A&E. And if it's an office hysteroscopy, i.e. they call it community hospitals, i.e. it's a building somewhere in the middle of nowhere, it's either an ambulance job or they literally have to be driven or drive themselves, because they're not always told not to drive to themselves to the hospital. And the complication rate for office hysteroscopy for diagnostic is simply not lower. It is for operative, well, again, the actual percentage, it's marginal. I know, obviously, when you take the risk of the general anaesthetic, because 1 in 140,000 have been quoted for an elective GA. The issue is that quite often, I know you say that some women don't want this and it can be quite terrifying. The problem is that quite often women don't want to be awake for this procedure, and this option shouldn't be removed. Also, that at one point it wasn't an issue having a male, it now becomes an issue, especially with some of the demographics that you'll have in this country. Also, it's not, you mentioned about a shift in thinking. Well, actually, there's an issue with that. Like you say, training, having students in at the current ratio that you're having is not acceptable. And to be honest, I question whether more than one student shouldn't be allowed in anyway, and then you should be asking them out of the room. You should just be saying, oh, and this person's here to watch. No, the issues are that quite distressing issues. Also, you mentioned light sedation. Well, great, that's great. However, that's not going to always be sufficient for operative procedures. Heavy sedation will sometimes be needed, which I do wonder why you've gone for light. Is it because you're not actually having an anaesthetist? Because let's face it, that's where the real money saving is coming from, by not having an anaesthetist. Also, your tailored protocols for pain relief in one of the videos I saw, not perfect, but it's certainly a lot better than what we have in the UK, because what we have in the UK is we don't have any in the UK, it's non-existent. However, I would say it'd be good if you actually offered light sedation for diagnostic. Now you go, well, there's no need. Well, the figures in the UK suggest otherwise. Now this is particularly high, but in one hospital in the UK that trialled the virtual reality headsets, showing pictures as a distraction technique, got the severe pain, which is a VAS score of over 7 out of 10, down to 40%. Without it, it was 75%, and this is for diagnostic, this is not for operative. So this also brings me on to another point of being realistic. You talk about minimum discomfort. Well, the reality is that quite often some women will still find this very painful, even with the pain protocols you have in place, and will need a general. And in the UK, there's quite a lot of gaslighting and blaming the woman for making a fuss instead of just saying, oh, perhaps we should stop. Again, reality check. One of the videos talks about removing a polyp. It says this is often well tolerated as it isn't an inclusion. Well, the testimonies of women I've heard first-hand and second-hand is that, quote, they were scraping me off the ceiling. Quite often there is inclusions, and there's often nerve endings that shouldn't be there. And don't be fooled by manufacturers of Metatronic and Hologic. I know Metatronic for 5mm polyp removal, fibroid removal system say there's only need to use anaesthetic 5% of the time. You really need to ignore manufacturers in this and actually trial this independently, because they don't actually give any real evidence for this, and that's a point that you should be promoting proper regulation for this, because at no point, in my opinion, should you actually be doing this in office. And I mean by in office, I mean actually in office. I don't mean in clinic, a part of the hospital that you were describing. Also, there should be laws that GA is still offered, and light and conscious sedation is still offered, and proper counselling that this can be painful if you go for a light or non-existent pain relief option. It's often unrealistic, and that's one of the problems of the doctors doing it. They've done this in GA, and now all of a sudden they're having to deal with the patient awake, and in some instances they will be fidgeting around. Now that means a shift in authority, i.e. the HCP or the HCA needs to have the authority to actually stop the procedure, which is simply not happening in the UK. I spoke to one gynecologist and he said, quote, I think with my 27 years experience I will be able to determine when it needs to stop. And he was quite shocked when I said, oh, you could ask the patient. They're simply, consultants are simply not equipped to be dealing with patients quite often. And as you say, the nurses run it. Well, we're finding also the training standards are extremely poor. And I did see a video showing a bovine tongue as a stop it. There is, in the UK, it's £2,000. It'd be about 3,000 Canadian dollars. A proper simulator, and although the simulated wombs are about £45, they come with several polyps. However, the issue with this machine is that it doesn't have pain sensors. Now, these simulators are useful for teaching the 3D aspect of it. However, you still need proper simulators that the Italians use, and they have to get a score of 8 out of 10 before they're allowed to go onto a patient. So it isn't just a matter of setting up the clinic, the cost of the clinic. It's also that you need to prove a certain level of competence, which is you're just assuming they're good enough. That should not be assumed. So I think I'll end it there before I witter on too much. But my overall gist is that yes, you've got pain protocols that are far better than in the UK, but still not really, in my opinion, sufficient. Also, you need to be teaching a realistic expectation of this to clinicians, is that they will have failure rate. There will be a relatively, compared to other aspects, a high failure rate, and they need to accommodate this, and that even with sedations and all this, there will be instances where they need to stop and they need to hand authority to someone else in the clinic, and you're not talking about that sort of training aspect, and I think it needs to be addressed. Thank you, bye.